everyone, and I hope you continue to enjoy your lunch. I want to apologize to the audience in this part of the room. I don't mean to give you my back. I'm sorry. But good. You have the monitors. And I want to thank all of the panelists for taking time to be here. I want to get started off on a positive note. You know, a lot of times when we moderate these panels, we want to tend and we talk about what the problem is, what has gone wrong, what's not going right, et cetera. So I want to start by asking our panel here, who has done a lot of hard work for many, many years, to give us one thing that maybe none of us in this room knows about, that is good news on the work that you and your group has been doing that is currently benefiting us or will benefit us in the future health-wise. So I don't want to pick on anybody, but I'm going to go ahead and pick on you.
Listen, you know, public health has been saving lives through prevention. You know, if you could get your hand around one thing, we've made it a big attack on the single leading preventable cause of death, tobacco. Tobacco utilization is down, and we should celebrate that.
Dr. Frieden, that's great.
He took mine, so I'll say vaccination. Because of vaccination and the Vaccines for Children program that's been active now for exactly 20 years, there have been millions of fewer illnesses, hundreds of thousands of fewer severe illnesses, and we're saving $3 for every dollar we spend on immunization in the healthcare system alone, and $10 in society for every dollar we spend. And industry and NIH and CDC all work together to bring vaccines to market. Then CDC works with state and local health departments and doctors from all over the country, and in fact all over the world, to get those vaccines delivered so that we save the lives that can be saved.
So I'm going to say something that's a positive that's going to sound like a negative to you. And that is the opportunity that we have in prevention when we have every year, still, despite these efforts, $96 billion in healthcare-related smoking costs, as well as more than 100,000 people every year dying from obesity. And that sounds terrible, except for one thing. We know what those things are. We know what the health impacts are. And we know that we need to prevent those, and we need to get better at that. But it's nowhere like the situation that we're in with so many other healthcare problems where we still don't even understand what's causing them, what we need to do about them. So we have this tremendous opportunity. If we could only put it together and say, boy, all that money that we need to spend to take care of those healthcare problems related to smoking and obesity, we need to draw some more of that into the realm of the behaviors that lead to those problems, preventing those behaviors. It's a golden opportunity that's right here in front of us.
Perfect.
As a result of work that the agency that AHRQ has funded, and with our colleagues at the CDC and CMS and the tremendous energy in the private sector, hospitals are in many ways safer than they were 10 years ago. Central line infections in ICUs have been reduced by 40%. We published report results recently that showed that adverse events altogether in hospitals have declined by 9% from 2010 to 2012. There is still a long way to go, but that represents 15,000 fewer deaths in hospitals, $4 billion in lower healthcare costs. So much work still needed, but progress as a result of evidence that public health research has produced.
The happiest news is that we are all living longer. And that is a cause for celebration. And we're doing that for all sorts of reasons, many of which you've heard along the line. We are not a burden, as some of the folks along the road would tell you. Legislators tend to think that older people cost us more and are a burden. I am not a burden. And I think one of the best things that is happening is that we are recognizing that healthy younger people have a much greater chance of becoming healthy older people. And recognizing, in fact, if I may borrow France's expression from the previous panel, from K to Gray, that is the best summing up of a life course approach to healthy aging that I have ever heard. And I believe that it behooves us to bring science and public health together to make sure that we take that life course approach to healthy aging.
And I can attest that you are not a burden. My father lived until he was 95 years old. He was as sharp as a whip and worked until he was about 86. And the day that he stopped working, he said, "Well," he said, "I'm tired." And he kept on working after that, not as much, but yes, you're correct. We are living longer, and we can live very healthy lives. And with that said, with all these accomplishments and what we can look forward in the future, yet we don't see the funding. And we see that I'm moderating a panel that's called Code Red. And how can we stop this assault, okay, on funding for research and development and so forth? And I want to take time and have Dr. Frieden answer this question with regards to Ebola. And is this not the prime example of why we need to really invest in this nature of science and prevention and so forth?
Well, let me first say it really is wonderful to be here. I think the Research America organization, the group, the commitment is critically important. As I told Mary, only for you would I have taken an hour off from Ebola, because that's about all I'm taking this week off from Ebola. It is really an amazing crisis. And of course, here we go talking about Ebola again. But I just would say that the costs of failure to establish a core level of public health services are mind-boggling. I think the Ebola epidemic is worse than is recognized generally. It's worse not only in the number of cases, reported cases are a small and decreasing fraction of the total because systems are increasingly overwhelmed. It's bad not in terms only of the number of patients, but the devastation it's causing to healthcare systems. I was just in all three countries. Empty hospitals. Those are patients not being treated for pneumonia and malaria, not being vaccinated, not getting treatments that would protect themselves and their community. And already we're seeing food prices increase and political stability decrease. This is a huge health and security crisis, and it's increasing so rapidly despite maximal efforts. We have today 100 CDC officers in the field working on this. It's the largest international response in CDC's history. And it's not going to be over for a long time. Now, if we could just replay the tape. If 2 or 3 years ago, we had put in basic systems that would do three things: find, respond, and prevent. These are three core things that every community needs to be able to do. Find health threats when they emerge. That didn't happen here. Respond effectively. That didn't happen here. And prevent wherever possible. If we had done that with a tiny fraction of what we will spend on this in the coming weeks and months and years, we would have prevented these outbreaks from getting out of hand. And there is no more painful, tragic, or moving an example of the failure to ensure prevention than the devastation that's happening in West Africa today.
To any of you on the panel, do you believe that part of the problem with Ebola could be that many people see it as a disease that is not affecting us here, that it's because, it's across the ocean, and that's why attention is not being paid to it?
I think that's definitely the case, that in the U.S. we tend to feel pretty comfortable that we do have systems in place that do most of the things that Tom laid out. We're very good at finding and interdicting. However, it would be very, very possible, just a slightly different kind of pathogen, for us to see an epidemic arise in a place like Western Africa that we wouldn't easily be able to protect ourselves from. I mean, it's just slight variations, for example, of the MERS virus, which is similar to the SARS virus that most of us have heard of, where there can be, where people can move around before they're infectious. It's more possible to introduce some of these into populations. an issue that I am particularly concerned about, which is the development of antibiotic resistance among pathogens, and the fact that worldwide the rate of antibiotic resistance among the most important human pathogens is continuing to rise. We're doing very little about it. And if we are to see a rise in the United States spread of antibiotic resistant pathogens, we're not going to be able to control that very easily. And so I don't think that we have the degree of concern that we ought to have because of the fact that, as you said, with the Ebola, that we do have ways, I think, of securing ourselves from spread of that virus. At least at this point, that's what Tom tells us.
Well, I also think that our public actually thinks that we have a solid, rock solid public health system in this country because they haven't watched the degradation of the health system over the last several years. Yes, we made lots of investment in insurance coverage, but at the same time, we lost over 40,000 workers in public health in our own public health agencies in this country. We built up a very nice biodefense infrastructure over the last several years, tragically since 9/11. So what do? Like we do for every other public health intervention, as soon as we think we got our kind of hands just a little bit around it, we cut the funding, remove the infrastructure. So I am not convinced that we will be able to provide the kind of response that we would like to respond to should Ebola enter this country. And by the way, we've already got dengue, we've already got chikungunya. I mean, it's not like we haven't had new emerging diseases in the last few weeks. We absolutely have.
Mr. Waters, I wanted to ask you, Pfizer does a lot of work globally, and so does the fact that we see public funding being cut constantly, and that's something I want to address later on, but does that put more pressure on the private sector?
Yes, it does.
How do you handle that?
You know, first and foremost, the public health of any nation is the responsibility of the government of that nation. It is no one else's responsibility. But no one can do this alone. And I think what I see as a very positive response is that we're seeing far more appetite for public-private partnership, for governments and the private sector working closely together, whether it's in research or whether it's in delivering public health, or you'll hear people talking about capacity building. I don't like that term because I believe that in actual fact the capacity is there. It is a matter of unleashing it and freeing it up to deliver what it's supposed to be doing. I think it behooves us all to recognize that we should be in this together and that working together and breaking those barriers down. And I welcome the increased appetite to partner.
One of the things that struck me while I was doing some research for this panel is just the seesaw. It looks like a little roller coaster, the funding year after year. And so how on earth, Dr. Frieden, as somebody who directs the CDC, how do you plan? How do you, I don't want to put you on the spot, but do you even have enough money to confront this whole situation with Ebola? But how do you plan from year to year?
Let me, before he says that, no, he doesn't.
Again, he took my line. I will say that public health really is a best buy. It's what protects all of us. It's what keeps us safe. It's what prevents problems from coming into this country. And every dollar we invest is going to pay off. It's going to pay off in fewer infectious diseases. It's going to pay off in less cancer, less heart disease, less stroke, less diabetes. And our challenge is to try to make sure that we have the kind of partnerships and momentum so that we can build on the successes we've had so far and protect the country and the rest of the world from threats that emerge like Ebola and drug resistance, which are going to be ongoing threats. One of the challenges, obviously, is the year-to-year nature of funding. But what we always try to do is fundamentally make diligent use of every dollar entrusted to us and ensure that we can stretch that as far as possible. And part of that means partnerships. Partnerships with AHRQ, with CMS. We have a very robust relationship with CMS now that never existed before. And we're thinking about how we can be synergistic in getting the healthcare system getting more of a public health approach, if you will, and partnerships with the private sector, with philanthropic organizations, but fundamentally, exactly as you say, public health is a responsibility of the government, but the government can't do it alone.
And if I can chime in on the aspect that I think connects to the research and what a couple of them just said, the capacity is out there. It needs to be mobilized. It also needs to be educated, and it needs to be informed. And what I mean by that is that it's not enough to say, don't just stand there, do something. We need to make sure that what we're doing is going to be effective. It's going to be the best use of the resources that we do have. They'll never be unlimited. And that requires research. It requires research. It requires education. And we have a huge struggle with maintaining an adequate amount of funding for research, especially when it comes down to applying what we know. We can learn the fundamentals about what causes disease. We can identify potential avenues for prevention, but we need to be able to take those things into the field and do trials and determine where we have the evidence about what works. A scattershot approach, which is what we often end up doing, will often, that we'll take down whatever we're trying to take down. But we're wasting a lot of bullets, and there are a lot of other problems that we aren't addressing because of the fact that we aren't sure how to target our efforts.
Mr. Kronick?
I would add to, I think you asked a really excellent question to begin the segment about, is there a perception problem? And you asked, was there a perception problem about Ebola and the threat to the United States? And Tom and others gave excellent answers to that. There is, I think, a much broader perception problem, and that's that many people, I think that, well, maybe we have some problems with affordability, that healthcare may cost too much. And there's some understanding that there are some access problems, and certainly the last couple of years and 10 million new people newly insured, there's some focus on access, but that most people think quality and safety are just fine. And there's a perception problem because I think everybody in this room probably knows that that's not the case. As Beth McGlynn showed 10 years ago, 50% of recommended services aren't received by Americans. Lots of preventive care that isn't received. Big problems with safety that we have made progress on, but there is a perception problem that practice is okay. And then a second perception problem, which is I and my colleagues have not done as good a job as we need to do in explaining the effects of the research and the evidence that we generate on improving the practice of care. And so the Ebola perception problem that you asked about is certainly very important today. There is a much broader, I think, two perception problems that we need to be working on here.
And really just, if I may pick up on that for a minute, healthcare, we spend a lot of money on healthcare, and yet just take two simple things. Hand washing in hospitals, not being done reliably. As a result, lots of hospital-associated infections that could have been easily and inexpensively prevented. Second, control of blood pressure. If you ask a very simple question, what's the way to save the most lives with medical care? The answer is actually quite clear. Improve blood pressure control. And yet, despite everything we spend, for the 68 million people, Americans with high blood pressure, only about half of them have it under control. And most of those who don't have it under control have insurance, saw the doctor twice last year. So we have so much room to grow in improving quality, and that will give us such a better health return on our health investment for dollars. And to get there, we need evaluation, we need programs that are rigorously tested. We need to scale up what works. We don't need the boutique programs. We need the programs that are everywhere quickly. And understanding what works and how to scale that up is a critical role for public health, research, healthcare to do together.
Okay, so I'm sorry, did you want to add something?
Just a very little advertisement for the agency. We are issued a funding opportunity announcement and are moving towards awarding grants to work on exactly the problem that Tom is discussing. We'll be awarding grants to work with small and medium-sized practices around the country, up to around 6,000 physicians who'll be taking care of 9 million people, to try to figure out what kinds of supports these small and medium-sized practices need to make progress in improving control of blood pressure, also cholesterol, aspirin, and smoking, the kind of ABCS of heart health.
So I hear what you're saying, and some of the, I think, what you might be saying is that people don't really take this seriously. And a lot of the people who may not be taking it seriously are those who can approve funds in Congress and who do the voting. And for example, I understand there's legislation right now being introduced by Congressman Lamar Smith that would set a whole different criteria. I think it's for the Science Review Foundation, something like that, in order to get funds. How do you feel about that legislation, and how would that even begin to damage or hurt the work that your organizations do? I can go ahead with you.
Yeah, I don't know the legislation, but let me just say that there's somehow this belief that if you see your doctor twice a year or 4 times a year, that somehow magically that's going to help you. It's wonderful to see your doctor 4 times a year, but that's a checkup. And I think people need to understand that we haven't crafted a system which allows people to be healthy. You know, we haven't crafted communities so they're walkable, bikeable, green. We haven't crafted communities so that there's no wrong door for you to go when if you're going for your blood pressure and it's high. That there's a process that gets you to someone to help you understand why it's high and to bring it down. You're in your pharmacy a whole lot more than you're in your doctor's office. You know, some people certainly in the grocery store 3 or 4 times a week. And there's a little machine in most of them where you can take your blood pressure. But even if they take that blood pressure and it's high, there's no looping mechanism to get them back to get that taken care of. So the problem is that we don't understand how to craft a system to ensure that people can be healthy. And I think that's the kind of funding and research that we need to better understand. But when we talk about doing that, then they call it the nanny factor. And I always say, why would anyone spend money to do something that's not going to work? We're just simply trying to find out what works and trying to spend money to do that. And that's what prevention research is all about. And to the extent that someone wants to put in legislation to help us fund that, that's wonderful. But my experience has been a lot of this legislation, and again, I don't know about that piece, but a lot of this legislation has wonderful titles, which doesn't do exactly what we need.
Mr. Waters first, and then Ms. Goldman, go ahead.
I think seeing your doctor 4 times a year is better than not seeing your doctor at all.
Absolutely.
And I think there is an opportunity for you to talk. I agree about the pharmacist. I think, certainly I can speak for my industry, I think we've ignored the pharmacy profession and the nursing profession at our peril. Because I always remind my colleagues that doctors have no idea what our pills look like. Pharmacists and nurses do know what they look like. And I think that reach any way we can reach people, because there's incredible complacency about health. If you look at the flu vaccine, and Pfizer doesn't make a flu vaccine, so I can talk about this, people just don't get it. They just don't get the flu vaccine. If you go to Rwanda, you will they aim for 100%. Vaccination rates, and their human papillomavirus rate is at about 85 or something, and it's only at that because they only introduced it a few years ago. Where there is political will, you can achieve anything, and I believe that is really what an organization like Research America and everyone in this room can do, is make a difference, is sweep away that complacency and try to raise political will.
I mean, what I would say to Congress about that is that it's very important to make the right diagnosis, before coming up with a remedy. And it seems to me that what certainly people in industry are seeing, which Congress doesn't seem to be seeing, is the value of prevention, the return on investment. So more and more, I see corporations investing in prevention among their employees, and much more aware of the linkage between prevention and ultimately the productivity of their employees, how happy they are, the healthcare costs. And that message has not gotten through to Congress. And that does involve, unfortunately, more expenditures for research than they're making today. But the payoff in terms of the bottom line for the American public, the taxpayer, is potentially tremendous. It's enormous. And how we get them to understand in the way that a company president can understand how this all impacts the bottom line, I think that that's a challenge that we have in communicating to policymakers, because they tend to focus on only one piece. And some will only be looking at the research while others are looking at the CMS costs, and they're not putting that together.
So, Mr. Kronick, I wanted to ask you, you all are saying the same thing. The connection is not being made at all. So where is it that we are failing? Where is it that maybe your organization is failing? We all know that Congress can act if the pressure comes from the bottom up, and the bottom up are the voters. So is that where we really need to start with the community? But where is the failure, do you believe? Where is it that your organization might be able to do better, and that you would like to see them do better? And in what time frame? I don't mean to put you on the spot.
Is the easiest part of that question to answer, and the time frame is yesterday. I've been the director at AHRQ for about a year, and have been working hard with some success, but more needed, to very clearly tell the story of the effect of the work that we have funded, and also to working on trying to make sure that we don't just produce evidence, but that we work at making sure that the evidence is understood and used. And we do have some remarkably good stories to tell. I mean,
But why have those stories not gotten out? And maybe the media is the problem. I don't know, but you tell me.
We need the help of everyone in this room. It is, as everybody knows, there's a tremendous amount of information all around, and it is difficult to get attention to information, especially when we are not so able to identify individuals whose lives we've saved. We have funded work that has shown that low-income children are getting too many prescriptions for antipsychotics. And that has resulted in action by state Medicaid programs and others to reduce the use of antipsychotics. But it's hard to find a child who is so much better off now. So it doesn't make such great headlines as potentially work that would find a cure for cancer. So it's a somewhat more difficult story to tell, but I take responsibility, and certainly am working as hard as we can at trying to tell the story as clearly as we can, as well as trying to make sure that the evidence actually is understood and used. We have in the past, I think, probably put too much effort on just generating the evidence. And we are pivoting now to working on dissemination and implementation. But we need help from everyone. We are a relatively small agency. We have about 1/100% of healthcare spending in the United States goes to AHRQ. There's a lot of other messages out there, so we need help on this.
I saw you nodding your head there for a minute.
Well, I think that the question you're asking is a really important question. I wish I had, a simple answer, because I do think that what Research America does in terms of bringing us all together to address that question is very important. It's so easy for us each to devolve into, what's the best thing for my school, for my agency, for my company, for my industry, right? Or my disease, the disease that I advocate on behalf of. And creating the larger vision and communicating the larger vision and finding a way to communicate the things that we know within that is what we haven't done well. You're absolutely right in pointing that out. And we need to be challenged to do that. It's one of the most important things that we can do.
Dr. Frieden, as head of the CDC?
I think we need to have an approach coming at this from multiple angles. What we've seen is that some of the best partnerships and the most effective ways of informing people are working with patients and families. To give you an example, Consumers Union has worked with many individual patients who've been had to deal with hospital-acquired infections, and they've really moved the ball. So getting individual patient stories out there makes a really big difference, and we need to be able to tell those stories well. Second, no one should ever underestimate your ability to have an impact. I'll just give you 2 examples. One, all of you, if you connect with, educate, inform, advocate with the people who you know in Washington or in state or in local government or policymakers or other areas, you can have a huge impact, especially if you're not in government. Because government always, someone will say, well, you're saying that because you're out for your own entity. But if you see what's really needed and you advocate for that, that's going to have a much bigger impact than other advocacy. And the story I'll tell about this is when the first management job I had in public health was running the tuberculosis program in New York City. And there was a New York coalition to eliminate tuberculosis. And when there was a change in mayoral administration, the president of the New York Coalition to Eliminate Tuberculosis wrote and said, there's a rumor that you're going to stop the renovation of the chest clinics, which the prior administration had committed to. And that letter went to the mayor and deputy mayor and now to the commissioner and deputy commissioner and ended up on my desk. I didn't know what to answer because maybe they're going to cut our clinics. So I wrote back kind of a mealy-mouthed answer saying, well, we'll look at it, blah, blah. And it went all the way back up and came all the way back down with a note from the deputy mayor saying, no, tell them we're going to do it. And that one letter preserved our clinics. And the New York Coalition to Eliminate Tuberculosis was actually one person, Charles Ehlers, a former cured tuberculosis patient who made a one-man deal. So never doubt what you can do with well-timed and heartfelt, sincere request.
You told me you were a troublemaker. So
Yeah,
I want to ask you.
The answer is we need to have resource allocators, i.e. elected officials, who don't talk about research with their mouth, but support research with their vote, and we need to hold them accountable for that. And we have lots of folks that say, well, you know, we can't do it because we don't have any money. We have lots of money. This nation always spends money on what it wants to. My God, we just had 13 years of war and going on, and we borrowed the money. I'm not so sure why we can't invest in research. My father said to me when I got my first paycheck that you should pay yourself first. And I would argue that we should pay ourselves first with research. That is a sound investment. I'll steal Tom's line again. It's a best buy. And I don't get it. You know, when I hear someone says, well, I support research and da-da-da-da, but they don't vote for it, they lose all credibility. But we also need to make sure that we have committee chairmen in these appropriations committees that support research and not ideologically don't support the evidence. And when someone in leadership puts people in these jobs that really don't support research, then we need to tell them, you know, we don't think that's a good idea. And we need to call them to task. And I think that it's good for advocacy organizations to do that. But the way to really get that done is, as Tom said, is your aunt's got to go there and talk to them. Your cousin's got to go there and talk to them. When they see me coming in the door, they know exactly what I'm going to say. So we need Auntie Sue and Uncle Jones to go in there and bang on their door and demand that they support, you know, improving the healthy communities and support research.
You have here a room full of people who, if you could put one seed in their minds that could get that done, what would be that step that you would encourage them to do?
I would tell them to just go and meet a local or state elected official, and begin the process of getting to know them. When you don't have an agenda, just get to know them, because you know when you have a relationship with an elected official, and they learn to trust you when you don't need them for something. When you do need them for something, they're much more likely to listen.
And that's just a reminder that this is not a federal problem. This is a problem at the local level. We have counties and we have cities and we have rural towns
Absolutely.
Who are seeing their budgets cut and not being able to address the health issues in their community. Mr. Waters, you're coming from the private industry. What would you say needs to be done that is not being done? Where is the disconnect where we can just pull people in and say, pay attention, this will pay off?
Well, I believe that we are seeing an improvement, and the private sector is very good at developing individual drugs, assets. We know that. But I am seeing a shift within my own industry towards an appreciation of the impact of our research and discoveries on public health. And I would like to encourage that within my own industry. So everyone here in the pharmaceutical industry and the biotech industry, I would encourage us all to recognize the impact that our research and our work can have on public health. One of the problems that I feel public health suffers from is that it isn't nearly as sexy as science. All the billions that get spent in laboratories, people working in white coats and stuff like that. It's not nearly as sexy as going out there and vaccinating a village, or turning off a water pump in medieval London. But
just
it
that it
has
saves
a
more lives.
huge impact. It saves far more lives.
There you go.
And I think that's the message that we need to get out there is, again, we're back to Tom's, it's the best buy. And I think one of the things I am seeing is a renewed interest in vaccine research that is happening in the private sector. For hospital-acquired infections. I'm really seeing that, and I would encourage my colleagues in the private sector to keep that momentum going.
Mr. Kronick, go ahead.
I would just add that if, to Jack's point, that public health may not be as sexy as finding a cure for cancer, but if you think vaccinating people is not sexy, try finding the sex appeal in changing the delivery system so that 70 or 80% of people with high cholesterol have it controlled rather than 50%. Now, that's really hard to get a lot of excitement about.
Mr. Kronick, I wanted to ask you, and I asked this question when they asked me to moderate this panel. One of the things that immediately struck me was, well, if you're having budgets cut, and you mentioned, I think it was, all the number of people that have been laid off, that have had to be laid off in the research sector. How does that impact a young student, or maybe just even getting people to get involved? How do you attract people to this kind of science?
You know, I'll just comment that global health and public health have become some of the most popular undergraduate areas. There's a groundswell of interest in this area. We started a program for new entrants right out of college or master's degree called the Public Health Associates Program, or PHAP. We only can leave the application open for 5 days because for 150, 160 positions, we get 5,000, 6,000 applicants in 5 days. And there is just an enormous interest, and we send these people out to the front lines, and they love it, and the people who they work with love them. But we're only able to scratch the surface of both the demand and interest and the need with resources that we have available. And the result of that is that the field of public health is at risk of not having a pipeline of future leaders.
And particularly a challenge in creating researchers. And we work at the agency in funding education at a variety of levels, and as Tom says, the demand is way bigger than what we can supply. So there is a lot of interest, but difficult financially for folks who are trying to tool up in this area.
Goldman.
I mean, as a dean, I have to mention the NIH pay line. And because the fact is that most of the prevention work that we're doing as scientists is funded by NIH. I wish more of it were funded by the CDC. I'd like Tom to be in charge of more of it. But he's not. And when young potential researchers, even people who are very serious about research and very enthusiastic about it, when they see the pay line and when they look at statistics such as the fact that the median age at which people receive their first award is what, hovering around 40 right now, that's very discouraging. And it's also true, and this is in my experience as well, that a lot of our best research is done by young people. And that this is not to patronize them at all. When you look at people receiving the Nobel Prize, how old were they when they did that work? They were young. They're older when they get the prize. They were young when they did that work. And so we're wasting a lot of the creative energy that's available here in this country by making it so difficult for young people to do research, to become scientists, to come on board in the enterprise. And this is something that I think is going to have a long-term detrimental impact on us, not only in terms of health and prevention, but also our economy, because those are our leaders in the future. Who will be the next generation of, say, Tom Friedens, if it is so discouraging for people to go into our fields? And that's the way it is right now with the pay lines on grants, unfortunately.
Frieden, I wanted to take this into a different, Dr. Frieden, into a different direction. Health disparities is a big issue in this country. And how does this impact into research and development?
So we need to figure out two things. One is, what are the very specific things that are going to reduce health disparities? The second is, what are the general things that are going to disproportionately benefit populations that are disproportionately affected? And let me mention one of each of those. I mentioned blood pressure control earlier. Actually, high blood pressure and heart disease specifically is the largest single cause of the difference between life expectancy between black and white Americans in this country. So if we could do this one thing right, we would knock off a large part of the health disparities and we would help everyone. Second issue is teen pregnancy. Teen pregnancy all too often is the intergenerational transmission of poverty. And we've seen teen pregnancy rates go way down. It is a tremendous benefit for society. It's a benefit for families. We want to do that in every way that works and scale it up. And those are two examples of a specific program targeted at a specific population to provide more services, and a general program that will help everyone but help people who need it most.
Want to add anything, or you okay?
I'm good with time.
Okay. So, man, time flew because I just saw the sign for the 5 minutes go up, which means we only have 10 minutes for questions. But I just have one last question. And so if anybody wants to have a question, please put up your hand. They have mics all across the room. But I wanted to touch on something before we finish here. You know, there's certain researchers, research that is being done. And forgive me, because before I got here, I was speaking Spanish. And so when you, and I'm going back and forth, and I know that I've made up a couple of words, so I'm sorry. But I know that there are certain, thank you for whoever put, you know what I mean probably. There are certain research disciplines that are not taken seriously. And that some people may think that it's a joke, it's a waste of money. And a lot of it, I think, has to do, I think one thing I wanted to pinpoint, for example, was behavioral research. Is that one of the ones that is most attacked but could be the most useful?
It certainly could be. And, you know, there was a time when health disparities research was not considered real research. Social science research was not considered real research. Only the quote-unquote hard science were, and you couldn't get tenure. Well, you know, now our colleagues in the room can help us with that. All of you deans can certainly do that by promoting practice-based research, community-based participatory research, more behavioral research. The Guild controls that. And I think one of the things we can do ourselves is begin to value that work a whole lot more. After all, you know, if you know, we can figure out how to make me look like Tom, size-wise. The research that involved with that would save a lot of lives and reduce, certainly would make me a lot healthier. And I think that's the challenge. I think the behavioral research and all of that stuff is something we aren't paying enough attention to.
I think often, you know, people can attack something when they do it in general rather than specifics. I'll give you two specifics. We've been trying to increase HPV vaccination rates. Why is it not happening? So behavioral researchers, with everyone's consent, went into doctors' practices and actually listened to what pediatricians and parents said. And they weren't like, oh, you might not want to get this. It was, you don't want to talk about HPV now, do you? That was the common, that was an important thing for us to understand, for us to approach how we get HPV given. Second example, Ebola. One of the biggest challenges we have is burial practices. Remember, these are countries that don't have an undertaker system. So if somebody dies, someone's got to help that person pass and, you know, respectfully. And we need to understand what the traditions are so we can change them in ways that are respectful but are not spreading disease. Those are behavioral research, and they're life and death questions.
Ms. Goldman, Mr. Waters, and then before we can get, anybody has a question yet? Okay, go ahead.
So I would say nothing has helped behavioral science more than the Human Genome Research Project and sequencing the genome and realizing that while there is a major contribution of genes to most diseases, that we can't understand genetic causation of disease without understanding the environmental and behavioral triggers. And my own brother, who's a geneticist at the NIH, and he and I used to fight about this. He now has behavioral scientists right in his lab, so that's my evidence for that. But also that we are able to fund that kind of research today, and because people have become aware that no, we're not going to fix this just by understanding about genes, that we really do need to get down into the nitty-gritty of human behavior to prevent disease.
Lori, making up words is an essential requirement for science, so you would be a great scientist. So.
Thank you. Thank you.
In terms of behavioral science, one of the most important non-communicable diseases that gets completely forgotten about is depression. And that needs to be focused on. We're talking about heart disease, and I completely agree with everything that has been said, and blood pressure and smoking, depression. And the simple scale of knowing whether someone is depressed or not is to ask them, are you depressed? And we don't do that. We've learned, one of the first things you learn at medical school is don't ask leading questions, like you don't want to talk about HPV today. Well, ask a question, are you depressed? And I really do believe that would make a significant public health contribution.
I would add only, certainly behavioral research has come under attack, but there have been sort of equal opportunity attacks on a variety of other kinds of research as well, including comparative effectiveness research and others, and that the kind of main task we have is to uphold the highest standards of science and to demonstrate that the results of the research that we fund and conduct are really useful and creating change. And as Tom has discussed, there are examples with behavioral research. We have many examples from comparative effectiveness research also. We need to work at that.
Okay, go ahead. We're gonna have a question here and a question here.
Thanks. Lucinda Main from the American Association of Colleges of Pharmacy. And so I have to say thanks, Jack and George and the others that brought the pharmacists into the equation. And a particular shout out to CDC, and then I'm going to have a question that really picks up on this last stream. CDC believed that pharmacists could expand access to immunizations, and there wasn't a heck of an awful lot of evidence to go on. But now you walk down the street and you can get your flu shot in virtually 55,000 locations without an appointment. But the problem that I have found, I'm a social science researcher myself, historically throughout my career, the funding level for that work has been the lowest in comparison to lots of others. And there really are issues related to methodological credibility. But when your laboratory's the world, that's different research than when your laboratory is a pristine lab and it's a randomized controlled trial. And I just appreciate you're talking about what we could do to really push the envelope forward, both on funding adequacy, because the deans will pay attention to that, and the credibility of the science.
On the credibility of the science, it is the work that you and your colleagues are doing to train the next generation and to put forward credible research designs. And we fund not as much investigator-initiated work as I'd like to, but about $45 million a year of investigator-initiated work. And we see lots of very high-quality applications that come in, many more than we are able to fund. In terms of raising the pay line and the funds, I'm not allowed to lobby. I leave that to, I'm delighted that Research America is here.
I want to go ahead and get this other question in because I know that sign's going to come back up any minute. And
Thank you. Thank you. Yes, Fadia Shaya, University of Maryland, and also here on behalf of AACP fellowship program. So thank you for the comments and the question about if our mandate for public health is going to be to find, respond, and prevent, and all of that is going to be overlaid on a fabric of a public health system that's rooted in primary care networks where mental health is integrated. How do we know that we're doing it right, and when? When can we leverage, or how do we leverage our knowledge of HIT, the tools that we have available, social media, et cetera, to make sure in real time we're producing results so that we're continuously improving those systems?
Yeah, absolutely. This is about surveillance. Surveillance is the core of public health. It's what we do. It's fundamentally what we're trying to do. If there's something you'd want to say in one sentence in a kind of meta way, it's helping people base decisions on data. We spent the last 2 or 3 years studying which practices can get to good rates of blood pressure control. And we found that one of the key ingredients was a feedback loop that wasn't annual, wasn't quarterly, was monthly. So that every month, every provider was finding out how they did and how they did with respect to everybody else. And with that kind of feedback loop, you could get dramatic improvement in a year. If you do it every year, you might get improvement in a decade. So what's really important is investing in the systems that are going to give us real-time information for the decisions that need to be made that really are life and death decisions.
I know you wanted to say something, Ms. Goldman. You wanted to add something?
Oh, on the last point, but I think it's gone by.
Anybody else has a question? We have 3, 4 more minutes. You sure? Oh, come on. Okay, that's how good you guys are. You answered all their questions. We have one more. Okay.
Thank you for that very informative panel. I'm Catherine St. Hill, and I'm also a member of the ACP Fellowship Program. My question is, in terms of science, we've talked a lot about different aspects of science. And so my question is, how, as scientists, do you pull from the various levels of expertise that different disciplines may have, different professions may have, to solve some of these tough scientific questions?
Yeah, well, you know, public health is a team sport. We've been doing it for, you know, hundreds of years. I mean, the concept of bringing together people from multiple disciplines and focusing on a single problem. You know, that's exactly what's happened with tobacco. That's exactly what is happening now with the Million Hearts campaign that Tom and others are leading. That's really the centerpiece of what public health does is work in a multidisciplinary way to focus on a problem. And now our medical care colleagues are beginning to do a much better job of doing multiple disciplinary management of patients. And we're learning a lot from that as we share experiences. And again, we break the walls down between the guilds and create a system in which anyone can start the assembly line and anyone can stop the assembly line.
I would add only that in addition to the kind of traditional mix that we have had and that George talked about of various kinds of social scientists and physicians, we are increasingly realizing the need to bring kind of systems engineering and operations research approach into the mix, which we are doing at AHRQ, and a variety of healthcare organizations are doing as well. But, you know, very exciting and needed addition to the mix that we've had in the past.
Public health is a team sport, but it shouldn't be a competitive sport. And I believe we're all in this together. I think we're seeing that certainly in the universities with improvement in interdisciplinary partnership. And I think that behooves us to see that we truly are working in this together.
We have a gentleman here and a young lady back there. And so I think the microphones are making their way.
I can speak loudly. Your field suffers from when you're successful. A lot of times people don't know about it. You prevent something from happening. SARS didn't make it into the U.S. and so what, right? Do you have metrics or methods or mechanisms for sort of showing what you either might have saved or did save? It seems like that would be compelling to the public, certainly, and maybe to politicians.
We have been doing that increasingly. I think Rick mentioned the same thing, is making apparent that which is not so apparent. So the tens of thousands of deaths that didn't happen from vaccine-preventable diseases, the tobacco deaths that didn't happen because of the progress there, that's absolutely something we're doing more of and need to do even more of.
And let's do a field test. We'll count after this meeting how many people get sick from drinking the water. Probably not going to happen.
Yeah. Go ahead.
I think we can all say that we weren't quite ready for Ebola and that we didn't spend enough money when we could have to get therapies and other things online. I remember working on that 8 years ago. So my question to you as public health people is, what should we be focusing on now? What's coming? What's going to happen in the next 3 to 5 years that you know we're not ready for now?
Well, globally, the number one issue is global health security. We've been talking about this for years. We've had a pilot project with tremendous success, but we're not at scale. We need systems in all of the weak links, all of the blind spots, all of the places around the world where the next Ebola or MERS or SARS or H1N1 may emerge, so that right there it can be found quickly, responded to quickly, and then we can all together prevent it. That is the leading need, and as we work to stop Ebola, we're going to have to put into place systems that would have prevented Ebola in the first place and that will prevent the next Ebola or other health threat in countries all over the world.
And I want to take upon, thank you for your question, to end on that note, and each one of you to address that question and wrap up. And once again, it boils down to one thing, and it's about funding. And how do we get the level of funding that you need to go on doing the work that you're doing and confronting the things that we are not talking about right now, but that you have the knowledge that we could confront as a nation in the next year or so, the next 5 years, or the next 10 years. And I'm going to start with you, Mr. Waters. I'll give you a break.
Antibiotic resistance, without a doubt. And there needs to be incentives to those who will develop and discover the next antibiotics, which is largely the private sector.
We need to tell the story more clearly and more effectively than we have about the effects of the evidence that the research creates. The tens of thousands of lives saved, the improvements in health, and the reduction in the rate of growth of spending. And we need your help in getting that story to people who are making decisions about funding.
I think it's a matter of return on investment, and that prevention is the best investment that you can make, and whether that has to do with keeping antibiotics effective globally, reducing childhood obesity, which we know is a looming disaster, or for that matter, how do we get the people who continue to smoke to quit smoking? How do we help people quit smoking? And those are questions that all of them have enormous consequences financially, economically, not only in the U.S., but also globally.
I would just add protecting Americans from threats, and that includes things like drug resistance and global health security, and then ensuring that we're maximizing the value we're getting for our healthcare investments, because today we're not.
You know, we're not the healthiest nation that we can be, and so clearly we need to create a movement so that every American believes that, and then that they're demanding on our resource allocators to demand that they fund it.
Thank you very much. So I guess we're all challenged to see how we can tell this story. I need to do better in telling the story and paying attention when I do get those press releases, but I think that you all have touched on something. There has to be a better way. You know, everything is about a pitch and how you pitch. And so maybe we need to start with the organizations that you have within your own entities that are the ones that are supposed to communicate to everyone else the message. So maybe it's the way you've been crafting the message. I don't know. I'm just throwing that out there. But just sometimes, look, I can tell you that sometimes we do make that call about something that is medical, and you'll call at 9 a.m. and I may not get a call back until 5 p.m. And then you have missed out on communicating your message and what is important. So those are all just, it's a very complex issue. There's a lot of components to it, and I want to thank you all for the work that you're doing. I pray God continue to guide you, and that we'll have many more successes in protecting our nation from diseases, and that we'll be a healthier nation. Thank you, and thank you all.